I was thinking, Prof. Rez, we haven't skipped a beat. Like, when was the last time we canceled Friday VMR? Do you remember?
I will say this, when you work with Robbie, you never skip a beat. There are no summer breaks. There's no
Got it.
breaks whatsoever.
100%. This is summer break right here, this next hour.
This guy's a machine.
Look who's talking though. Prof. Rez has been working 19 days straight and still has a beaming smile on his face, which is incredible.
This is just the euphoria of knowing I'm done today.
Well, we have to kick off Prof. Rez's words farewell with a bang. I hear from a secret spy that we may or may not have a case presenter. Hold on, let me let other people into the room. Sayed Zina, hello. I'm not sure. Oh wait, I can't see you yet. Somebody tells me you might have a case. Is that true?
That is absolutely true. Hello, everyone.
Amazing. Well, I couldn't be more excited. Do you want to say a quick hello and reintroduce yourself to the crowd here and on YouTube?
Hello, everyone. I'm Sayed Sina from Iran. I'm a general practitioner, currently working as going through my obligatory military service.
Salam, Sayed John.
Hello, Reza.
حالت چطوره؟
Reza Jan. Reza Jan, this is the first time I'm talking to you, but it's so nice.
خیلی خوشحالیم. به رابی میگم یه چایی برات بیاره.
قربونت رضا جان. خیلی طرفدارتم.
سلامت باشید. خیلی ممنون که اومدین. خیلی خوشحالیم.
قربونت.
شارمین هم خوشش اومد از این صحبت ها. رابی رو باید بگیم چایی برای همه بیاره.
You know, the best part of all this is I can pretend like I know what you're saying and I can make it seem whatever I want it to be.
You should start learning Persian, I think.
I really should. Maybe you should teach me. And of course, all I really want to learn for the first 2 years is how to insult Reza in all the ways possible, okay?
Tu ne parles pas français, Ravi.
All right, y'all. Well, before we derail this, I'll pass the mic to you, Sayed Sina, to kick us off with the case.
Okay, I will. This is an interesting case, and I think it will hold some very interesting teaching points. And I will narrate this as it was presented to me. It was a case for colleagues, and Robbie is aware of. There is a group that we sometimes share difficult cases and ask for opinions. This was presented to me like this, and I'm going to present to you like this. There are some gaps in some places, but I'm sure the overall experience will not be bothered. Okay. For the first aliquot, our patient's story begins as she presented with nearly a month of low-grade fevers and night sweats, but no weight loss. As I know how much you love to be teased only in the first aliquot and not be given the whole picture, so this is all I leave you with.
Thank you so much. It's going to be so hard for me to discuss this case in English because as I hear members in Iran, it's bringing a huge smile to my face. I will be very brief here. So we have a young woman who's presenting with 1 month of fevers. And when you hear the term fevers, what your mind should do is convert that term into inflammation. I want to make one point here that fever might be the most specific sign of inflammation, but it's not the most sensitive marker of inflammation. In fact, an assignment to the chat, what are the 9 to 10 markers that would suggest your patient might have inflammation? Because we're going to be looking for those markers as this case unfolds. Think about the exam, laboratory assessment, imaging. So once you do convert this to inflammation, and you can be pretty convinced that this is probably inflammation, as opposed to this patient, you know, wearing a million layers of clothing and having hyperthermia. There are other causes of temperature rise that are not fever by the definition of cytokine rise in the hypothalamic set point. But once you convert it to fever, then the exercise becomes the I made mnemonic. And the I is capitalized for a reason, because you always have to search for an infection. Because when you treat cancers, M is for malignancy, A is for autoimmune disease, when you treat those two buckets, you're often providing immunosuppression. So if there is an infection that's hiding somewhere, you will worsen the condition of the patient. So infection, malignancy, autoimmune, drugs, DVT, and endocrinopathy. As the time course continues, typical infections become unlikely. For example, UTIs, pneumonias, these kinds of infections become less likely when you have 1 month of symptoms. And this is not a young female, as I mentioned, it's actually middle-aged to elderly woman. But you're not done with the infection category. You have to think about atypical infections that come in the form of mycobacterial disease, in the form of fungal disease. So infection is still there, but all of a sudden the capital I becomes lowercase I as the time progresses. And I'll leave it at that. We're going to need much more data, but I think for the step 1 is just fever, inflammation, look for other markers of inflammation, and try to find out what's driving this inflammatory process, apply the I made mnemonic, but everything else that it tells us will help navigate our thinking and the focus of light. What do you say, Robbie, that term you use, the focus of light? This is the spotlight. It will help identify the spotlight.
Tu ne parles pas français.
All right, back to you, Mr. Sayed.
Wonderful. So the whole picture is a 65-year-old female presents with nearly months of low-grade fevers, which were also associated with feeling cold and drenching night sweats in a way that patient described that she needed to change her clothes once in the early stages of the night and once when she got up in the morning. Also, there were non-specific arthralgias, and she reported headaches. And when they asked her about where exactly hurt, she showed sides of her head. And as pointed before, there were no associated weight loss. With the addition of a non-specific chest pain, patient was admitted to infectious ward for the workup of brucellosis. Brucellosis is one of the infections that is very endemic in Iran alongside with TB. And because of high suspicions for that and the fact that she was she lived in rural areas, and that naturally comes with direct and indirect contact with many exposures, she was admitted to the infectious ward. Here comes a little bit of knowledge gap. We don't know many things that they have done in that admission, but we know for sure that TB was ruled out, brucellosis was ruled out, and COVID-19 was negative, HIV was negative, hepatitis workup was negative, a TTE and also a transesophageal echocardiography was significant for only a mitral valve prolapse. And then after she was ruled out of these etiologies, she was admitted to another ward, namely the neurology ward, because of suspicions for giant cell arthritis with an ESR of 120. And with a clinical vignette compatible with this, she was discharged with low-dose prednisolone, and arthralgias and body aches abated, but low-grade fevers and night sweats remained.
Sayed, I think you're showing us how complicated this situation is. And I think that it's complicated because I don't think we really know one thing. We know one thing for certainty, and we don't know the other thing quite well. You may have cast some doubt on the degree of evidence of inflammation because the patient didn't lose any weight. And you might have said, oh, well, is this some sort of inflammation mimic of fever? Because 1 whole month of fever without weight loss is unusual, but then you have to merge that with the fact that this person's ESR is very high. So I think now there's almost no doubt that this person has robust inflammation. And you're in a situation where the fevers continue, and you've done a pretty thorough workup for infection. And that workup of infection has included even investigating occult cardiac sources that has been unrevealing. And so I think you can, with a high degree of certainty, move away from infection, especially since the patient is being trialed on a low dose steroid and hasn't gotten worse yet. So I think the combination of a very thorough workup for infection and the lack of dramatic worsening, although it may be too soon to tell on prednisone, moves you a little bit away from the infectious hypothesis. And I think whenever you have headache and inflammation and no infection, I think giant cell arteritis is a precise diagnosis to entertain, and one which would be further evaluated with a temporal artery biopsy or CT of the chest to look for aortitis. So I think that's definitely a very possible scenario, the one that you would like to confirm with radiographic or pathologic confirmation. And I think here that's the tension in this case, because it 1 month of fever, night sweats, and bitemporal headache is very consistent with giant cell arteritis. So either this is a giant cell arteritis picture or a mimicker of that condition. And I think there are many mimics of that condition, too many to list. But I think the operating framework in real life would be, one, are there some other simple things to rule out that are easy to do so? An example would be hyperthyroidism. Two, and so that's one. Two, what is my temporal artery biopsy and or what does my CTA of the chest show? Are they compatible with this diagnosis? And three, are they not compatible with this diagnosis? So for me, I'm sitting here, I'm going to pretend I'm taking care of this patient. I'm asking myself, are there simple things that I can rule out, like hyperthyroidism as a simple example? And then two, we already committed towards prednisone. So let's get the confirmatory test. And if that reinforces our hypothesis, we'll proceed down it. And if it negates it or minimizes it, then we'll have to put our thinking hats on again. So that's where I'm at, not thinking too hard, just trying to take the next logical step as guidance. Prof. Rez, what do you think?
I love the way you break it down, and what a fascinating case. And I appreciate the authenticity in which Al-Sayed is presenting this case. I will say that, like, probably your most important diagnostic step for giant cell, there's two. One is the epidemiology of the patient. So you almost never see this condition in someone less than 50, but as the age rises, the concern for it should rise. But probably your most important diagnostic test is steroids. This is one in which patients, when you mention steroids to someone with polymyalgia rheumatica or GCA, they improve like the next day. Like, I had a patient with polymyalgia rheumatica, Robbie, who couldn't comb her hair. She had an ESR of 40. I gave her Pred 20. And the next morning she was combing her hair. She made the bed in the hospital. It's that much of a dramatic response. So the thing that concerns me here, honestly, is the fact that this patient hasn't had a resolution of their fever or symptoms despite having steroids. So as you mentioned, Robbie, maybe it's too early. Maybe they only got one dose and were released from the hospital. But the lack of response, if it's multiple doses, really almost eliminates the condition, that possibility of GCA.
Okay, guys, this case is a roller coaster. In the next 3 weeks, as the symptoms did not improve and the patient got severe vertigo as she was getting out of the bed, also with ataxia and vomiting. She presented again to the emergency department, and this time she was admitted to the rheumatology ward. Prednisolone was titrated up to 20 milligrams TDS, Cinnarizine 25 TDS, dexamethasone 8 BD, and later betahistine was also added to the medications. Patients' fevers had abated and night sweats had improved drastically, but vertigo was still going on.
Wow. Okay, this is interesting because this is a roller coaster of a case. I'll try to be brief here and then give the mic to Robbie to comment. But the patient's now coming back with ataxia and vertigo. And the thing to note about dizziness and vertigo is that if you have any other symptom, prioritize that symptom because dizziness has a very broad VDX. There's a really great article by David Newman-Toker on how to approach it. But like the first step in approaching dizziness, is there any other symptom? If so, shine your spotlight on that other symptom. And here for me, what's striking is the ataxia. Assuming it's not from the dizziness and this patient actually has ataxia, you can break that down into cerebellar ataxia or sensory ataxia. So the physical exam will be crucial, meaning I would be evaluating for dysdiadochokinesia, dysmetria, shin to heel testing. And I would want to know, is there any truncal ataxia? Basically, I will try to pinpoint this either a cerebellar disease or a sensory disease. And I would be assessing the reflex responses and such, because once you localize it to one of those pathways, you can make progress. Though I'm a little cautious because I don't know how much the dizziness is contributing to her ataxic gait. And maybe for the dizziness, I'll pass it to Robbie to comment because I look at this one dimension, I'll pass it to Robbie for the other dimension. The improvement with the steroids, I will still be cautious because even high dose steroids will mask any occult infection or even malignancies, specifically lymphoma, that might be hiding in the background that could leave a widespread signature to their disease. Robbie John.
Oh, my dear friend, let me tell you a story. I have a salt shaker, you know, the thing that puts salt and stuff, and I absolutely hate it because it never like it's either too much or too little. Like it's just the dynamics of it are a problem. And what does that have to do with this? I think the very moment that you sprinkle steroids into a case and the patient doesn't get definitively better, you're always like, did I give them too much or did I give them too little? And I think that too little means that she has some sort of untreated non-infectious inflammatory process that's going on, or did you give them too much and now she has an infectious process as a result of her immunosuppression? So now the only problem is we know we have a much more an easier problem to solve. The problem now has some localizing features finally. You know, before we were like, where is this inflammation? Now we have ataxia, vertigo, vomiting. That is a very specific syndrome. But the problem is we've now introduced more possibilities, including an previously undiagnosed continuous disease process, or we've added too much salt into the mix and now we have to figure out two different things. So I'm a little bit more nervous about how many diagnoses we have to uncover. But at least that's tempered by the fact that we know where to proceed. And I think the next process to proceed is to evaluate the common denominator of cerebellar disease and vertigo, which is the posterior fossa. To start, it can localize in other places like the peripheral nerves and even the meninges, but at least you know where to go. You still don't know what it is or how many things you're going to find.
آقا سید نمک بیش از حد گذاشتی تو این غذا برای آقا رابی ترش شده.
Guys, as much as I would love to give you physical exam and other findings, it wasn't presented to me and I didn't get to communicate later to ask these further questions. But the case has still many things for us in store. So the first aliquot, while admitted, it was found out that she has microscopic hematuria of 25 RBCs per each high power field and a creatinine of over 3. 3 weeks before, she had normal creatinine and a normal abdominal and pelvic ultrasound. Patient is given a mini pulse of cortisone and creatinine doesn't move an inch. ESR is still sitting tight on 122 and he has leukocytosis of 14,000 with 19% PMN predominant. O2 saturations have been around 94 and steady for the whole duration of the admission. Abdominal CT, pelvic CT, brain MRI negative. ANCA, ANNA, anti-DSDNA, anti-Rho antibody, anti-CCP, anti-LA, all negative. the patient was tested for rheumatoid factor 3 times. The last time, I mean, during the whole disease process, the last time RF got positive. RF was weekly positive in the last exam. And also there were many other negatives. I will tell you from here. HRCT of the lungs, again, negative. 2 times COVID test, negative. Sonography is still negative for abdominal and pelvic. And CT scan of head, in addition to MRI, also negative. CT scan of the sinuses, negative. Special ear CT scan, negative. Many negatives. And actually, it was like a dead end for diagnosis. And patient's vomiting had resolved, but vertigo continued in a way that the patient even was feeling like falling, even when she was resting. And this situation, this was the exact situation where the rheumatologist consulted the group with idea of would it be a good idea to give her a full dose corticosteroid pulse therapy or not?
Before we reflect on the large amount of data that I think is very helpful, maybe I can just ask you 2 questions. One is that why count 130,000 or 13,000?
White count 14,000 with 90% PMN.
Okay, 14,000. Okay. And along with the microscopic hematuria, do you happen to know if there's also proteinuria or we don't know?
As much as I would love to give you that proteinuria or dysmorphic RBC or RBC Cas, I don't have that data.
Okay, no problem at all. Okay. So maybe, Prof. Rez, I'll just make a case for understanding the urinalysis, because I think that is really a powerful place here, and then I pass the mic to you to reflect on all the other data. And I think that, when you hear fever, headache, and night sweats, you jump to giant cell arteritis, which is a vascular disease process. And then you're trying to find out, are there any other evidence of other vascular disease processes elsewhere, including temporal artery tenderness, subclavian stenosis by measuring the different pulses, getting a CT to look for aortitis. So the whole theme in the evaluation of giant cell arteritis is to look for other evidence of vascular involvement. And here you might get some evidence for that vascular involvement in the form of the kidney stuff, but we'll talk about why that's not definitive and why that's a problem. So the analysis begins with what causes microscopic hematuria. And when you confirm that the patient has microscopic hematuria, you know that they're bleeding somewhere in their urinary tract. And the question is, are they bleeding from an anatomical lesion or are they bleeding from a vascular problem? That's no different than in somebody with having GI bleeding, finding a tumor or finding varices, either an anatomic issue or a vascular problem. Same approach to the kidney. Here we'll jump to use the CT scan to our advantage, which looked and saw no anatomical abnormality, which prioritizes a vascular issue. The vascular issue is then put even more in the spotlight because the differential diagnosis of hematuria plus AKI is very limited. Hematuria plus AKI equals either glomerulonephritis or urinary obstruction from the blood. So when you have no urinary obstruction as evidenced by the CT, no mass lesions as evidenced by the CT, microscopic hematuria and AKI, this should give you a working frame of glomerulonephritis until proven otherwise. What would prove otherwise? Absolutely no proteinuria. That would make your case for glomerulonephritis much weaker. And what would help you prove otherwise is if you biopsy the kidney and don't see evidence of glomerulonephritis. But the working model for this patient should be glomerulonephritis, presumed glomerulonephritis, though you haven't confirmed it. And so I think that gives you a lens by which to analyze this case and a framing by which to gain some clarity on what's going on. So I think that's a good working model, and I'll pass the mic to Prof. Rez to see what he thinks about that and to incorporate the other data that we have.
I love it when Robbie gets us to the center of gravity. It gives his co-discussant some confidence. I will say this. So the question I'm going to answer is that if I was in that group chat, what would I recommend for like the high dose steroids? I would be nervous about it, to be honest. And the reason I would be nervous is that I still don't have a diagnosis. And I can understand early on if I'm concerned for a life-threatening process or like vision loss in GCA, that I would want to give high-dose steroids, or if there was a strong concern for an autoimmune mediated glomerular nephritis, like lupus nephritis. Like if I had a patient who came to the hospital that was young and I was really concerned for lupus nephritis, I would have no problem giving them pulse dose steroids and then doing a biopsy the next day, because it's not going to influence all of the nephrons in the kidney. But in this case, I would be nervous. And what's making me nervous is that we've had now months of symptoms and we've had steroid exposure and we still don't know what's happening. So instead of giving a pulse dose steroids, I would say, hold on one second. Like, we're dealing with a subacute process, subacute to chronic process, and the patient is not showing us all of a sudden that something needs to happen right now. I have a little more time to investigate. And so what would be my next steps? It would be the following: probably a kidney biopsy, especially if there's albuminuria, because if we frame this as a GN, then the differential diagnosis narrows. And that kidney biopsy, when you study it under light microscopy, when you study it under immunofluorescence, you will likely get an answer. The other thing I would consider here is a PET CT, because there's something that's driving all this. And that PET CT might show you a focus of FDG avidity that leads to sampling and ultimately a diagnosis. So if I was part of that chat on day 70, day 80 of symptoms, I would say hold off on the high dose steroids. Let's see if there's albumin in the urine. If there is, let's get a kidney biopsy. Let's study it with light microscopy with immunofluorescence. And let's think about, that pathway. So that's sort of where I am right now. Back to you, I'll say it.
Incredible discussions, guys, incredible discussions. And after the case was put in the group and discussions were made, with high suspicion, higher than ever suspicion for a single diagnosis, a previous diagnostic test was requested to be repeated, and this time yielded a correct diagnosis. I'm very interested to see how that changes the equation for you, and to see your thoughts on that final data point.
I see. So, okay. So, Saejan, you want us to guess what that diagnostic test was?
Yes, what that
Okay,
diagnosis
all right.
might have been, and what the final diagnosis.
Okay, perfect. Okay, so that's great. So maybe, Ravi, you and I can dance, and maybe I'll summarize the case and we can go back and forth. So this is a 65-year-old woman, no known past medical history, who's presenting with months of inflammation. I've converted fever, night sweats, and the high ESR to just inflammation. Her primary clinical syndrome includes a headache, dizziness, ataxia, but her MRI of the head was negative. So MRI negative CNS symptoms. The labs most notably showed an AKI with hematuria. So it comes down to elderly woman, subacute to chronic inflammation, hematuria, MRI negative, headache, dizziness, ataxia. I think, Robbie, like I agree with you completely. Like the only focal point we have in this case, with everything being negative, is what's happening in the kidneys. So I think we can make that leap now, given we have no other data, to say that this process is involving the kidneys, not to say that it can't be involving other organs or other vasculature in other organs, but there is a focus at the level of the kidney. And if we're at the level of the kidney and we're having, the only challenge right now, though, is it would be so helpful to have the albumin in the urine, because I like if we have albuminuria, then we can really focus on the glomerulus, and then we can unleash a schema that's based on the kidney biopsy, which includes posse-immune, immune complex, and anti-GBM mediated processes. But it would also allow us to exclude the step-up vessels to the kidneys that can cause hematuria. Here, I'm not referring to the glomerulus, which is like your final stage before you start filtering blood into the nephron, but rather to the medium vessels that precede the kidney. So there's two things I'm activating here, RG, and I'm going to pass the mic to you. One is, are we dealing with the GN? And if we are dealing with the GN, even though the ANCA was negative, it doesn't rule out posse-immune glomerular nephritis, which accounts for 60% of glomerular nephritides. And as someone ages, their risk for ANCA-associated vasculitides become more common. In fact, this is most autoimmune diseases, especially ANCA, GCA, those are the diseases of the middle age to elderly. I don't like anti-GBM for this chronicity and the fact that there is no pulmonary symptoms. So I can't rule out posse-immune. Only our biopsy and immunofluorescence would show that. Under the immune complex mediated, I don't think this is going to be something that's going to be normal complementemic. I would send complement levels. I'm not sure if they were sent, or we don't have those yet. I think it would be hypocomplementemic. And there you're back to where we are, the IMATE, infection, malignancy, autoimmune. For the infections, I don't think there's, I just don't like infection too much, but it's always a possibility that there's something occult that's driving a GN. Malignancy-wise, lymphoma. So I would be interested in the LDH, and I think lymphoma is certainly on the DDX, and it can cause all of this. But then another shift is, could she have some kind of medium vessel vasculitis? Let me pass the mic to you to add any additional thoughts and to carry on that conversation.
I think that's absolutely superb. Like, if you listen to that, you should listen to that over and over again, just how comprehensive that analysis is, zooming in and zooming out. And I just want to say that, like, what is the value in doing what we're doing now? It's actually to stretch your probability assessment. There's no way that any of us can say that 100% this is the diagnosis. That's not correct. But what we're trying to say is, with very limited data, what is your best guess so that you can actually extract more refined probability analysis? And that comes with having to simplify things. If you don't really know what problem you're trying to solve, you cannot make a probability assessment, so you have to make assumptions. And you saw how Prof. Rez was like really struggling to call this glomerulonephritis because he wants to know the albumin. But in order to generate some sort of probability assessment, you just have to assume that, because you can't generate a probability assessment of nothing. You have to say, okay, glomerulonephritis, and here's my guesses. But you have to be authentic to the fact that you're guessing it's glomerulonephritis. So for me, I think I don't have anything to add to that. And the only dimension that my mind was also analyzing was the intriguing fact that this syndrome seems to have been evolving in front of us. So what's that dimension? That dimension is the creatinine was presumably well enough to get contrast images on the first hospitalization without any problem. And then shortly thereafter, the creatinine is 3 and the patient has hematuria. And so this seems to be glomerulonephritis developing right in front of our eyes. So that made me think, wait, is the RF becoming positive of any actual significance? And was the RF actually initially negative simply because we tested it too soon? So I started to say, okay, well, what are the diseases that are associated with a positive RF that could adjust the probability assessments in this case? And it's definitely not rheumatoid arthritis. There's no way that rheumatoid arthritis does this. But how does RF factor into the world of glomerulonephritis? And the first reflex response should be that, hey, a positive RF is associated with endocarditis. Could this person have culture negative endocarditis? And you're like, well, we already tested her for brucella. The other big one, the other two big ones are Bartonella and Coxiella. And then you look and you see, wait, she lives in a rural place. Could she have the other Ella, Coxiella? And that analysis is weakened by the fact that there doesn't seem to be overt hepatic or permanent pulmonary involvement, which Q fever usually does. So that a little bit less likely. Bartonella is a very good piece here. And if you find out she has a pet cat, that would skyrocket. The only problem with Bartonella and her is most cases of Bartonella glomerulonephritis, a vast majority, are described with two features: men who drink alcohol, so a lot of alcohol. And so here you would reduce that probability. So positive RF for endocarditis possible, needs to be assessed, but made less likely by all the things we discussed, but also made less likely by the fact that you did a TEE and didn't find anything. So what else would an RF fit here? RF would fit with cryoglobulonemic vasculitis and glomerulonephritis. Now, is that a possibility? Of course, because cryos, even if they're tested, can be notoriously negative. But the clash with cryo in this case is the fact that most patients with cryoglobulonemic vasculitis don't fit what we're seeing here, because what we're seeing here is a isolated renal predominant deep glomerulonephritis without spilling over into the skin, without spilling over into the peripheral nervous system, and without spilling over into the lungs. And that problem representation, along with the positive RF, makes me most worried about MPA, or microscopic polyangiitis, because MPA is also associated with a positive RF and notoriously causes a deep, devastating renal predominant glomerulonephritis. So we, just like Prof. Rez did with glomerulonephritis, we're not really sure if that's actually what's going on. I don't think I can say that, that RF is really involved in this case. It may be a complete distractor. But if it is, endocarditis, cryo, and MPA, and the most compatible fit for all these things would be MPA. I think at the end of the day, it's hard to make progress without biopsying this kidney, definitive progress. But an older patient with fever of unknown origin characterized by arthralgias, a positive RF, and a deep GN is evocative enough of microscopic polyangiitis that, geez, if I didn't have the tools to biopsy her, at this point, I would probably say, unless there's a cat involved, let's go with the steroids, because at some point you have to make a decision if you don't have access to the biopsy. Yeah, those are my thoughts. Any Prof. Rez, well, I've been rambling for a while, so any other thoughts come to your mind that you want to share before we?
No, I think that was beautiful. Very interested to get more story, and I, honestly, like, I know we're hanging our hats on a GN just because we don't have other data. You have to be cautious. Like, I would repeat the UA. I would make sure that there's proteinuria. This is all part of our exercise, our mental exercise. But I would want a little more data before making that leap.
You guys are incredible. This is not a thought exercise in a limited information setting, but it's also in a limited resource and maybe a suboptimal healthcare system setting. And this is invaluable. As you guys mentioned, you guys nailed it. Thoughts and considerations for endocarditis was very high for this patient, and request for a repeat echography, TEE, was done, and we got only one answer after that. Vegetations were seen and antibiotics were started, and the patient improved drastically. Vertigo resolved, creatinine was going towards being normalized.
Wow, that I have to tell you, I think we certainly thought of that, but I don't think I expected it, honestly. Can you share more what you know, where the vegetations were, what the bug was, or was it all just basically that this patient got better with antibiotics, which is a pretty good case for an infection?
Guys, I don't really know which valves were involved, 1 valve, 2 valve, 3 valves, no information on that. And our contact is very limited to a Telegram group that we are on the same page. We don't know each other in person. And the case is that once endocarditis was thought of, everything started to make sense. Let me put it all together. A subacute bacterial endocarditis, fever, and fever, and feeling cold, night sweats, arthralgias non-specific, headaches, chest pain, vertigo, and vomiting have been reported. There is a whole articles on neurological manifestations of endocarditis. But as I know, they must usually show on MRI. But why didn't this patient show? Maybe the septic emboli were very small, or maybe that, I don't know about that. But hematuria, it can be both emboli mediated and can be immune mediated. So two kinds. So about GN, I am not really sure that whether if it was a GN or an other type of kidney involvement, and maybe these would stay from in the unknown sides of this case and unsolved sides. But as you mentioned, RF incredibly helped in this. Why should a patient who doesn't have RF develop RF in the middle of a case, in the case resolution? And we even were thinking of ANCA negative post-immune RPGNs, and even though we didn't even know if it was a GN, but we were even considering everything. But the fact that something that defines and fits all of the symptoms in one place, and also many negative rheumatological tests, but only a single RF that developed later, really late in the disease process. Actually, 50% of endocarditis, subacute endocarditis people have RF, which was really incredible to know. And I actually developed a schema for positive RF, which I don't think we will have time for it at this time. And the most important was the immunosuppressive therapy wasn't really helping. It was helping a little symptoms, and then other symptoms were developing. And even the patient was given a mini pulse, as Reza mentioned. In this situation, really, suspicions should be high for maybe what if we are wrong from the get-go. And after wondering for many minutes, I started to feel this obvious case. I only recently started to understand, because the patient had TTE negative, but later I studied, even TTE isn't perfect, maybe 80 to 100% sensitivity, but 80, sometimes 80 sensitivity, and we shouldn't say always 100. And TEE is operator dependent. Maybe that person who has written that article paper is attending of 20 years, 30 years, and maybe the person who is doing it in a rural hospital, I don't know where, it is not trained enough. And that was playing a critical factor. But the patient's attending physician was so determined this is rheumatologic that even she gave it a mini book. This is predetermined closure, I think. When we determine the category of the disease before, maybe we should do it. And it's kind of a bias. And this was really right. And let me conclude by saying that this is really unfair. This is unfair to the physician who was dealing with the patient, to the discussions, and most importantly, to the patient itself. This was really unfair. And this brings me out to the suboptimal care that this patient got. Nothing can hide the fact that this patient got suboptimal, both in the terms of DX and RX, suboptimal. But everyone who is participating, who has additional studies, is participating in CBC, knows AKI first approach perirenal, renal, and then postrenal. And then when hematuria, 3 Cs, clots, and then casts, and many other things. And for the hematuria, most important thing is to know, is it GN And if it's GN 3 weeks, only 3 weeks for a GN, and that fills the criteria for an RPGN and requires an instant biopsy. But these were never done, and these are not really fair sometimes to the patients. And this emphasizes the CPS Solver's mission that is doing some incredible things, and we can't thank you guys enough.
Wow, I'm just blown away. All I say, that was such an incredible case presentation. Thank you for bringing it to this forum. And I just want to applaud you and your colleagues that you have a group that helps, others arrive at a diagnosis. I think that is just inspirational, and it just brings a smile to my face. And I'm so happy that patient had the likes of yourself and your colleagues to think about her case. And I'll just say one thing that, and I love to hear Robbie's cognitive autopsy on this case. If you look at this mitral valve prolapse, if you ask the question, who actually gets endocarditis? There's like two things you need for endocarditis. One is you need a vulnerable valve, and 2% of the population has mitral valve prolapse. The second thing you need is some kind of transient bacteremia for infective endocarditis. This patient actually did have the vulnerable valve, and I actually saw that TTE, and then I shifted away from the TTE, but it just is so humbling, this diagnosis of endocarditis and how it can mimic so many conditions, subacute endocarditis. This is just, it's almost, Robbie, like the thyrotoxicosis that I always miss on every CPC. This reminds me of that. But yeah, I think this was a phenomenal case. And it's like, for me, the highlight is this: when is one negative study enough to exclude a diagnosis? To me, this is the highlight. And I bet you if you did get that PET CT, that something would have lit up, there would have been something. This is what ID doctors always recommend when there's a concern and you have a TTE that's negative. It's like looking for a focus of infection. So for me, it's like, without the exam, how, and then the patient didn't even have stigmata of left-sided endocarditis that we could view, whether it was splinter hemorrhages or specific findings on the fingertip. So this was an incredibly hard case. But Mike, to you, I know Andrea is going to have a lot of teaching points, but Robbie, I would love for you to share your cognitive autopsy before we go to Andrea.
Yeah, I think that in this case, I think it's impossible to have arrived at the diagnosis earlier. You can see that the people taking care of this patient initially ran towards endocarditis faster than anyone with both a TTE and a TEE. And so I think the cognitive autopsy is to reflect on the sprinkling of the salt. And I think that it's very tempting to want to rush and make the patient better by adding in prednisone, but that has tremendous consequences. And you will never know if this patient just had a migraine and then developed endocarditis because of prednisone, or the patient had endocarditis all along. And I think that the only helpful negative test, the only negative test of any definitive value is the patient getting better. So you can put all the diagnostic tests and put negative in front of them, but the patient's getting worse, then those tests don't matter. So I think this is a great example of even places with access to TEE, that test is negative, but the patient's not better, doesn't matter. But I think the truth is that this diagnosing culture negative TTE and TEE negative endocarditis is a task of monumental proportion, which should allow you to take some grace in not nailing it perfectly. But the main reflection, I think, is I understand the urge to have the patient feel better, but you might add too much seasoning into the mix when you're trying with the prednisone. So I think the only thing that I would have done differently is not the steroids, but I wasn't there. And I wasn't there watching this patient suffer, and I've been very vulnerable to the tendency to try to get somebody better quickly, because we all are emotional human beings at the end of the day. Those are my reflections, but
I was laughing, Robbie, not at your like real sentiment, but you keep referring to seasoning and
yes.
you're
I'm
just
hungry.
starting to cook, my friend. You're not Chef Robbie yet. You gotta use those terms lightly.
All my skill set is adding salt and I don't do it well. So
But I feel, dude, I feel like every CPS episode, you come up with like a new theme, like spotlight, seasoning. The other time you were using one vocabulary word that's evading my mind, but it's
camouflage, is that it?
yeah.
Yes, I get very confused and delirious when I haven't eaten. So yes, I'm hungry. Alrighty, Andrea, please take us home, and thank you again, Sayed Sina, for an absolutely incredible case. We really appreciate it.
Thank you. So we started with a patient with fever. So Reza remind us that it's not the most sensitive for inflammation, but it's very specific, and always differentiate fever for any other cause of rise of the temperature. And when we think about fever, we think about our famous IMA mnemonic, that is infection, malignancy, autoimmune, drugs, DVT, and endocrinopathy. And a typical it also made us think about typical infections like Mycobacterium. Because the patient received steroids, it's good to remember that if the steroid did not make it worse, it move us away from the diagnosis of infection. We thought that the patient may have giant cell arteritis because you had headache, inflammation, but especially bitemporal headache. And then when we try to create a schema for dizziness, we always have to think about a companion symptom. And when we have ataxia, always differentiate between cerebellar and sensory ataxia. Another thing about the salt, the seasoning, is that high dose steroids can mask infections and malignancies. So we have to be careful with that. Once you give the steroid and the patient does not get better, we can feel we have too much, or maybe we have too little. So we have to think before administering steroids. Because an important fact is 20% of the population have mitral valve prolapse. Thank you very much.
Thank you, Andrea. I'm sure that was a very hard ask to recap that case, and really appreciate you joining us today and doing so. All right, y'all. We have a VMR doubleheader tomorrow. We'll hope to see you at one of the sessions. Take care.
À tout à l'heure.
À tout à l'heure.